Hello, I'm Dr. Erika Hamilton, the Chief Development Officer Late Phase and Director of the Breast Cancer Research Program at Sarah Cannon Research Institute, and I'm going to discuss ER-positive metastatic breast cancer and specifically what has happened recently. We're going to go through current treatment options, new ER-targeting agents with the monotherapy data, oral SERDs with combination therapy, and also moving oral SERDs up into the earlier line, and then also talking about some combinations with PI3, AKT, mTOR agents. So these are my disclosures to say that all payments are institution. I have no personal conflicts. And this is where we really stand with the treatment algorithm. Right now, almost without exception, first-line treatment is AI in combination with CDK4/6. Certainly, we use Fulvestrant as our backbone if patients have an early relapse on an adjuvant AI, or for those patients that have an early relapse and have a PI3 alteration, the triplet with Alpelisib is an option. And then for second line, this is where it becomes a little bit more complicated. We have combinations like fulvestrant abema or exemestane or fulvestrant with everolimus. We now have two FDA-approved oral SERDs, Elacestrant and Imlunestrant. And then we also have two FDA-approved targeted drugs for PI3 alterations, Alpelisib, and then Capivasertib, which also picks up a couple of other alterations, AKT, PTEN. And then once patients have endocrine resistance, we think about moving to cytotoxics. And really, that's where we think about moving to antibody-drug conjugates with data with Sacituzumab Govitecan, Datopotamab Deruxtecan, as well as Trastuzumab Deruxtecan. So our endocrine options fall in several buckets. I think people are most familiar with the selective estrogen receptor degraders, and sometimes people want to loop all of these drugs into the SERD buckets. But we have PROTACs, we have CERANs, and we also have novel SERMs, and we're going to go through some of this data. So first, let's talk about monotherapy data. Emerald is the one that we have had around for the longest. This was a phase 3 trial, straightforward design. Elacestrant versus treatment of physician's choice, standard endocrine therapy, fulvestrant, anastrozole, letrozole, or exemestane. Everyone had had a CDK4/6 inhibitor, and they had progressed or relapsed after 1 to 2 prior lines of endocrine therapy. And this is what we saw. We saw an improvement in progression-free survival among those patients that had an ESR1 mutation, 1.7 to 3.8 months. This was the population that this was FDA approved for. And you can see that the majority of patients had not seen chemotherapy. The majority of patients did have visceral metastatic disease, and a little shy of about half of our patients had ESR1 mutations. We also saw a trend that patients had more benefit from elacestrant the longer they had previously been on their CDK4/6 inhibitor. And in some ways, this shouldn't surprise us. If patients really have endocrine resistant disease, they're not going to get benefit from any endocrine therapy, whether that's a better endocrine therapy or a worse endocrine therapy. So our benefit really looked larger if we looked at those patients that had seen benefit from CDK for at least 12 or 18 months. So 8.6 months of benefit on 12 months of CDK4/6 with elacestrant, or 8.6 again if they'd had benefit for at least 18 months on CDK. So we recently saw data from VERITAC this year at ASCO. This again was a phase 3 trial of vepdegestrant versus fulvestrant. Again, post-CDK4/6 inhibitor in combination with endocrine therapy. Patients could have had additional line of endocrine therapy. They could not have seen chemotherapy or fulvestrant previously. And again, we saw the benefit in those patients that had ESR1 mutations. Fulvestrant gave us a PFS of 2.1 months. Vepdegestrant gave us a PFS of 5 months, and a very similar pattern here. What we did see was that this was a very clean combination. Most common side effect was 27% fatigue. Again, any grade. Vomiting and diarrhea was very infrequent, any grade, 6%. And we saw exceedingly low rates of dose reduction or treatment discontinuations. We don't have a FDA approval yet at the time of this recording from vepdegestrant, but it is under consideration at the FDA. Palazestrant is a complete estrogen receptor antagonist, or CERAN. So it blocks both the transcriptional activation function domains AF1 and AF2. And monotherapy in pretreated HR-positive disease resulted in PFS of about 4.8 months among all patients. And again, the same trend of having a greater benefit among patients that had ESR1 mutations, 5.6 months. So again, you can see these graphs over on the bottom. In terms of prior CDK, this was not universal in this study. About 63% of patients had seen a CDK. 2/3 had already seen endocrine therapy. Only about 15% had seen chemotherapy. And because this was a little bit more of a naive population, ESR1 mutations were a little bit less frequent at about 22%. Again, this was a phase 1 study. So let's talk about what we see when we look at oral SERDs in combination with CDK4/6. This was EMBER-3. This is also still being looked at the FDA. We do have an approval for Imlunestrant by itself. We do not have an approval yet for Imlunestrant in combination with abemaciclib. But this study looked at patients that had endocrine therapy, either quick relapse after adjuvant setting or progression on first-line AI with or without CDK4/6, and they were randomized to Imlunestrant, to standard of care endocrine therapy, fulvestrant or exemestane, or the combination of Imlunestrant with abemaciclib. About 2/3 of patients had seen CDK4/6 inhibitor. About 2/3 had already had a line of endocrine therapy for metastatic breast cancer, and about 2/3 has had a ESR1 mutation. So when we look at this Imlunestrant versus standard of care in the upper left corner, 3.8 months versus 5.5 months. And our benefit really was only for those patients that had an ESR1 mutation. And you can see this differential down on the bottom. When we look down here on the bottom, we're talking about Imlunestrant with or without abemaciclib. You can see patients without ESR1 mutations over on the right, patients with ESR1 mutations on the left. And so when we add the abemaciclib in here on the bottom, you can see that the benefit really is regardless of whether patients have ESR1 or not. However, this was a little bit of a tricky study design because we didn't have an arm that was fulvestrant with abemaciclib. And so that's really why we don't have an approval yet of the Imlunestrant abemaciclib combination. Now, what about when we look at PFS in ESR1 mutation and PI3 pathway mutant? You can see over on the left, Imlunestrant abema in the darker pink, Imlunestrant alone in kind of the salmon color, and then over on the right, CDK4/6 pretreated patients. And you can see that regardless, Imlunestrant abemaciclib doing a little bit better here when we continue to have a CDK4/6 inhibitor, but that this drug was obviously efficacious for both ESR1 mutations as well as patients that had PI3 alterations. In terms of overall survival, this was an update that we got just this past December in 2025 at San Antonio. We now see about an 11-month numerical improvement in overall survival with Imlunestrant versus standard of care in patients that have an ESR1 mutation. It's about 50% mature data, but 23 months versus 34.5 months. When we go down to the bottom of the slide at about 33% maturity, we see Imlunestrant with or without abemaciclib data not mature yet. So no evidence at this stage that continuing the CDK beyond progression improves survival, but clearly signs that it does improve PFS. So let's talk about oral SERDs in combination therapy with everolimus. This was data presented at ESMO 2025, the Vera study looking at giredestrant with everolimus. Again, these patients had had CDK4/6. They'd had up to 2 prior lines of endocrine therapy for advanced disease, giredestrant with everolimus, or standard of care endocrine therapy with everolimus. And you can see over half of patients having ESR1 mutation, the majority having 1 prior line of endocrine therapy, and about half having prior fulvestrant. And this is what we saw in terms of PFS. In terms of the top left, these are ESR1 mutations, 5.45 months versus 9.99. And when we look at PFS in the intention to treat population, 5.49 versus 8.77. So this was a clinically significant improvement, but really it was the ESR1 mutation subset that was driving this benefit for us. When we look at mutations in PI3, AKT, PTEN, you can see that this is consistent regardless of alteration status. If we do not have an alteration, 5.45 versus 9.99 months. If we do have an alteration, 5.55 versus 10.15. So essentially 5.5 months versus 10 months either way. So what about side effects? We do see stomatitis with the everolimus combination. We know that we can decrease this with topical steroids via the SWISH study, et cetera. We know that we can see anemia as well. We can see diarrhea, et cetera. But really not a whole lot of side effects increased with giredestrant. We don't see a clear increase in diarrhea or some of these GI side effects that we potentially could have. In terms of discontinuation rates, we had 17% of patients discontinue giredestrant and about 12% discontinue standard of care endocrine therapy. So here, early progression in ESR1, a single agent SERD versus SERD plus targeted therapy, really just looking at this cumulative data that suggests that when we use a SERD in combination with targeted therapy, it appears that we can overcome some of this inherent endocrine resistance, and this may be more effective than SERD monotherapy for many of our patients. So let's briefly talk about moving the oral SERDs up into the first line setting. SERENA-6 reported at ASCO 2025, so about half of a year ago at this point, and looked at an early switch strategy. Early switch meaning switch at the emergence of an ESR1 mutation in the absence of actual progression on a scan. So these patients were undergoing ESR1 mutation testing every 2 to 3 months, and if they popped positive, they had scans. In the absence of progression, then they were randomized to continue their AI and CDK or switch to Capivasertib with CDK. In terms of who these patients were, you can see the time of ESR1 mutation detection was really the majority at first test, right at about half. Almost all the rest were at a subsequent test, but median term months was right at about that 2-year time point. And you can see representation from all CDK4/6 inhibitors. About 3/4 were on palbociclib, about 15% on ribociclib, and about 10% on abemaciclib. So in terms of investigator-assessed progression-free survival, which was our primary endpoint, ctDNA-guided switching to camizestrant did prolong progression-free survival, 9.2 up to 16.0 months. A key secondary endpoint was second PFS or PFS2, and this also was prolonged with a hazard ratio of 0.52. There was a hearty debate of whether this was a fair analysis, since really this kind of in some ways compared 3 lines versus 2 lines. It's just we switched therapies in the absence of progression for one. So asking that question of, well, if we waited for progression and given that patient a 3rd line, how different would these really have been? But also some data looking like quality of life was better, and really some bone type pain being better. So asking the question of whether we might be improving patients' quality of life as well. So some other studies coming, SERENA-4, so very similar to SERENA-6 in the terms that it's first line and it's camizestrant, but asking the question of just upfront using camizestrant with CDK instead of having to look for ESR1 for a switch strategy. And Persevera asking a very similar question, but giredestrant with palbociclib versus letrozole palbociclib. So first line upfront as oral SERD with CDK. We await data for these. So let's move to novel targeted agents, PI3 mTOR. This is another new drug, Gedatolisib. Recent data just presented at ESMO 2025. Gedatolisib is a PI3 inhibitor. It inhibits not only PI3, but also mTOR1 and mTOR2. It's an IV inhibitor. It's once weekly, 3 weeks on, 1 week off. So a little bit different in the fact that it's not an oral inhibitor. This study looked at patients that had progression after AI and CDK4/6. They'd had less than 2 lines of prior endocrine therapy, did have pretty strict inclusion criteria around type 2 diabetes, could not have had an A1C greater than 6.4, no type 1 diabetes, and looked at fulvestrant gedatolisib, or fulvestrant palbociclib gedatolisib. And you can see a breakdown of their previous CDK in the bottom right. And you can see that about 80% of patients actually had visceral disease as well. Very significant progression-free survival benefit. Fulvestrant 2.0 months versus the triplet with gedatolisib 9.3 months. And compared to fulvestrant, co-primary endpoint with the gedatolisib doublet 7.4 months. We did see hyperglycemia and diarrhea. This was manageable. We did see discontinuations due to AEs in about 2.3% of patients with the triplet and about 3.1% with the doublet. So it did appear that we could control this as long as we very carefully selected for patients coming on based on those A1C parameters. So where does this leave us? What is our future treatment algorithm? Not a lot of changes yet in first line, but in second line, in these beige bars, this is how this might sort out a little one. Vepdegestrant might be coming for those patients with ESR1 mutations. Imlunestrant with abemaciclib could be appropriate for either no mutations or ESR1 mutations. Everolimus with giredestrant could be another option for patients that don't have a mutation, and we're really looking for targeted therapy. And then all the way over on the right, gedatolisib could be another option for our patients with PI3 alterations. So key takeaways are SERDs have demonstrated efficacy in ESR1 mutant HR positive metastatic breast cancer. ESR1 mutations are a resistant mechanism, but they also predict endocrine dependence. And so really finding patients with these mutations are quite important for us. Combining SERDs with targeted therapies can improve PFS outcomes. Vepdegestrant has shown benefit in ESR1 mutant breast cancer. And we really are looking at more places where we might be targeting ESR1 mutations, an early switch strategy in first line, might even be looking at upfront oral SERDs in the first line. And then what is practice changing from 2025? I think Vepdegestrant will be coming onto the scene for those with ESR1 mutations. EMBER-3, we had Imlunestrant approved in October of 2025. The combo with abemaciclib is still up in the air. We also saw a giredestrant, everolimus, and the imlunestrant abema, as I just mentioned. SERENA-6, not yet FDA approved, but certainly did show a proof of principle that switching therapy to oral SERD at the time of emergence of ESR1 mutation could extend PFS. And I think taken all together, this really just shows that oral SERDs are here to stay, and we're likely going to be moving these up into the earlier line, first line, and even adjuvant therapy. What's coming in 2026? Readouts from the first line upfront trials with oral SERDs, phase 2/3 data with novel PI3 targeting agents, and emergence of novel targeted therapies, CDK4, CDK2, KAT6, etc., to overcome resistance. Thank you very much.